My name is Fenoy. I'm a professor of neurosurgery and psychiatry and the director of functional neurosurgery at Northwell Health. I am going to talk to you today about two modalities that we use for essential tremor, deep brain stimulation and high-intensity focused ultrasound, how to use them, when, why, and how. The agenda of today, we're going to give an overview of what essential tremor is and the target we use to modulate that disease to make it better. One of the processes that we used is deep brain stimulation. It's what it is, when we can use it, and why we use it. Examples of that and the procedure itself. Also, we're going to talk about high-intensity focused ultrasound, the efficacy as well as the procedure, and compare the differences between the two. So, if we look at the treatments of essential tremor, it's been something that's been going on for decades, over 7 decades and probably earlier than that. Back in the 1950s, we had found out that essential tremor is really due to a fiber pathway that's aberrantly firing going through your brain. It's a degenerative process. And to fix that degenerative process, we create a lesion or a roadblock in this pathway that's in the thalamus. Thalamus is a node of structures that of where fibers pass through, kind of as a relay station. If we can intercept things there, we can stop the aberrant firing and improve tremor. So back in the 50s and earlier on, we would create a lesion there through surgery. We would place probes into the brain and cause a lesion. That is surgical, and it did have very good effect for improving tremor, except it was invasive and caused permanent lesioning, which is sometimes good. So that was the early stages. After that, we have evolved to doing non-surgical type of procedures to create the same type of lesion. That has involved stereotactic radiosurgery and gamma knife, ways where we don't have to do surgery, and through using radiation and a single session procedure, we can create a lesion in the brain at that same location. The problem with that, although it does cause good tremor reduction and is incisionless, is that it is radiation, which is not necessarily the best. We can't also visualize exactly as we're doing this procedure what we're trying to accomplish. We target, but we can't see real time that we're getting the effect. We can only do one side at a time, and we don't see an effect right away. Typically, when we create a lesion through radiosurgery, gamma knife, we have to wait a few months for an effect to occur. In 1997, deep brain stimulation, and even earlier, became really widespread. And this is where, instead of placing a lesion through a probe, we place electrodes through the brain to the same target area. And through high-frequency stimulation, we can entrain the cells to modulate at a normalized pattern. So we can still stop the tremor, but without creating a lesion. This is very efficacious. It's been highly used throughout the world. Over 200,000 patients have this type of device. The good news about this is that as a disease process such as essential tremor is progressive over time, that we can adjust the stimulation to contain the tremor at bay for decades. The thing that's negative about this, or somewhat of a drawback, is that it is surgery. We have to implant electrodes into the brain. That with that, there are the risks of surgery, of infection and bleeding. We do have to maintain the system, and there is a battery that is implanted. That is one of the most common options to improve tremor today. Then one of the other common options we have is focused ultrasound. This is similar to the incisionless procedure like gamma knife, but we don't have to use radiation. Instead, without using a surgery, we can focus ultrasound beams through the skull to create a lesion at that same location. It doesn't use radiation. Interestingly, great is that we do this in an MRI scanner, so we can see real time that we are creating an effect, and we can make adjustments. Also, what is unique about this is that we have a real-time effect at that same time we're creating the lesion. So we can see what is going on. It is not adjustable, unlike deep brain stimulation, but it is non-surgical. So the two current treatments that we are using, and the focus of the discussion today, are deep brain stimulation and focused ultrasound. So, essential tremor is a very widespread disease. Actually, it's the most common movement disorder. It affects an estimated 10 million Americans. I'd say at least up to 50% of patients don't get satisfactory relief from the medications or have side effects from those medications. As with most things, we try medications first. Those medications we'll get to in a second, but that is this first step. After we have tried medications, we consider and patients don't have an effect that they're happy with and their quality of life is suffering, we then continue to think of treatment options such as deep brain stimulation, or DBS, or focused ultrasound. DBS, though, has not been really as popular for essential tremor because patients may be a little bit scared of surgery. And so with that, focused ultrasound has become a lot more prevalent in the last 5 years because of that fear. They're both equally efficacious, and I will discuss the differences. So, as I mentioned, what we consider for essential tremor, well, there's many options before we get to the procedural intervention. One of the first options would be a wearable device, such as weighted gloves. You may have heard of a Calitrio bracelet. Well, these are weighted interventions and actually give a little bit of feedback to prevent your tremor. They're not doing anything to modulate your disease process. They will temporarily improve tremor. Commonly, after a patient is diagnosed with essential tremor, which is done by a neurologist, likely, or could be done by a family physician, typical medications would ensue. One of the most common was a beta blocker called propranolol. This is really a heart rate reducing medication and blood pressure medicine, but it has a good effect to reduce tremor. Another common medication that is used with its improvement of tremor is called primidone, which is actually an anti-seizure medicine. That also has a very good effect. However, it's not primarily used for tremor. It just has the side effect of reducing activity in the central nervous system and therefore can suppress tremor. Other medications, such as benzodiazepines, are also used. Clonazepam are anti-anxiety medications. They have the effect of reducing tremor as well. So once a patient tries medications and they're no longer effective, or they're having side effects that make it intolerable, then a patient could consider an intervention. The interventions are the ones I just mentioned. The most common ones we use today are deep brain stimulation and focused ultrasound for a neurosurgical intervention for tremor. So let's talk about what we're actually targeting when we look at an intervention. Well, the ventral intermediate nucleus of the thalamus is basically a nexus, a place through which fibers pass. It's a critical part of the pathway that starts all around the brain. It comes from the cerebellum, goes up to the motor cortex. It passes through here. This is the target area where we want to create a roadblock to prevent this aberrantly firing information for whatever reason to relay to the motor cortex and then create this tremor. So if we can create a lesion here, whether it's a temporary lesion through deep brain stimulation, what we call a functional lesion, or an actual lesion through focused ultrasound or otherwise, we then have improvement of tremor. So we believe it's this loss of cerebellar input to the VIM, thalamus, this area, that leads to this pathological oscillations in this tract that causes the tremor. So if we stop that, we will cause an improvement. As we mentioned before, surgical ablation was started back in the 50s, and we have done very similar things in other modalities, such as focused ultrasound. So this thalamus, is really a node within this larger pathway called, we like to call, the dentatorubro-thalamic tract, or cerebellocortical-thalamic tract. It starts in the cerebellum, in the back of your brain, the dentate nucleus, goes up towards the middle of your brain, and then onto the thalamus to the motor cortex. By intercepting that through stimulation or ablation, we can change that pattern and improve tremor. So this is what we may look at if we're looking at exactly where in the brain this tract is. We can see it in 3 dimensions. We use this. This is something that is very useful for surgeons when we're trying to plan exactly where we want to create this lesion. The red arrows here show work from a research that I've done a few years ago, where we have placed an electrode or an ablation target in the middle of this fiber tract that we have mapped out. So by identifying this fiber tract that we believe is aberrant, as it intercepts this target area in the ventral intermediate nucleus of the thalamus, or just as it's entering, we can modulate it and significantly improve tremor. So the first modality we're going to talk about in depth is deep brain stimulation. Deep brain stimulation, as I mentioned, are putting electrodes into your brain to the same target area and through wires to a battery pack that we put in your chest. And through high-frequency stimulation, we can entrain the cells within this fiber tract to have a normalized firing pattern and improve tremor. When do we consider deep brain stimulation? Well, an essential tremor is for patients that have tried medication, but the tremor is refractory to medication, meaning that they tried it, propranolol, primidone, or something else, and it's just not quite getting to the level of effect we want. And so with that medication refractoriness is something that's very individual. It differs per patient, Patient who has a very large tremor may be happy. A patient with a very small amount of tremor may be unhappy. That quality of life significance is very independent and individualized. So there is no specific quantification of medical refractoriness. We just have to try it. Try medication and see if it helps. If there are side effects, that's another very important thing. So say you're having medication that is having an effect, but you're having very much sedation or getting dizziness or nausea from the medication, such as propranolol or primidone. Well, those are side effects that would make you not want to take the medication to contain your tremor. So when that occurs, we then would want to consider a non-medication surgical modality of treatment, or such as deep brain stimulation or focused ultrasound for that matter. There is no age limit for deep brain stimulation. So I've been performing this in patients in their 20s up to my oldest patient was 86. As long as they are good candidates surgically, they have no heart problems or very other comorbidities that we like to call, then a patient is a candidate for this type of procedure. The biggest thing, as I mentioned, is the poor quality of life. So say a patient can't write or eat or drink very well because of their tremor in their hands. That causes a little bit of a social stigma. Maybe they're a little embarrassed to go out in public. Well, again, another reason for why we'd want to perform deep brain stimulation. Why consider DBS? Well, it's not just when, but why. And why is that we have a motor dysfunction, this tremor, that we need to improve. That's one of our biggest things. We know that medications are not adequate. Whatever we're trying is not good enough, so we need something else. The poor quality of life, probably one of our biggest things, that is very independently individualized. We don't know if your quality of life is different than somebody else's, and how long you can tolerate it. That's when you consider a treatment. Deep brain stimulation is certainly a great option. Probably the very important thing to mention is that this is not big brain surgery. In fact, we're just opening two small little openings in the skull to pass wires down to this target under very specific, precise trajectories to make sure that we're not causing a huge disruption to the brain. It's not like a tumor removal. It's not an aneurysm clipping. It's a very small brain surgery that takes less than 2 hours. Why deep brain stimulation over lesion? Well, as I mentioned to you before, a lesion is when we destroy an area of the brain, which is very important when we're trying to create a roadblock through this pathway to improve symptoms. But deep brain stimulation is reversible. So say we're putting this electrode into this fiber pathway, we can remove it if we need to, for whatever reason. It's not permanent. In fact, as soon as we shut off the stimulation, patient's tremor will return. Not only that, it is adjustable over time, which is very important. So essential tremor is a progressive disease. It starts out at whatever age it starts. Could be young, could be older. It's more prevalent as age increases. It may start as a small amount of tremor in your hands. That will increase in magnitude over time. And not only will it be in one hand, maybe in both hands, but also may spread to your head or jaw or voice. As your tremor increases in time, we do surgery to improve your tremor, but your tremor now, say you were to have surgery, your tremor at the time you have surgery is going to be different than it will be 5 years ago, just like it was different 5 years prior. We have the ability through the contacts that we're using and the amount of parameters that we're using in stimulation to adjust that stimulation over time to contain that tremor continuously. We have the ability to adapt to a changing disease state. So again, as this tremor changes, we can continuously modulate your circuit to have very good effect over time. It's not a single shot in time like a lesion. So that is an advantage that's very useful to deep brain stimulation. Honestly, it's the improvement of the quality of life. Deep brain stimulation plus medication is superior to medication alone. In fact, most patients, once they have deep brain stimulation for tremor, no longer take medications. But everyone is a little different. Why DBS? So this began in 1987 in Grenoble, France. It's been around for over 30 years. FDA approvals were in 1992. This is not new. There's over 200,000 implants worldwide. This is a tried and true procedure. I myself have done over 750 procedures of deep brain stimulation. It's very common for this treatment. And it's although some patients may not have heard of it, it is something that has been out there and is tried and true. So we're going to skip this and talk about the procedure itself. So the procedure, occurs in an operating room, as you would expect. So there's many different gadgets that a neurosurgeon has in the procedure that all help us make sure that this electrode goes to target and that we accomplish what we set out to do. So we have all these tools help us to make sure this is as quick and as efficient as possible. They all kind of work together, and we'll go through them in a second. So, as I mentioned, we kind of define the tract that we know is aberrantly firing in essential tremor. This is this yellow pathway that we see in the brain in many different sections. So when we see this pathway and we can map it and identify, we know precisely where we want to place this electrode, or the lesion for that matter, in the ventral intermediate nucleus of the thalamus or just inferior. That is something that is very useful, and we use this continuously. Not do we only want to identify that fiber tract, but we have this large O-arm is what we call it, is a three-dimensional scan in the operating room to confirm that we have everything at the right location. We will do microelectrode recording. In Parkinson's disease, this is more prevalent, but basically we want to listen to cells fire as we're placing this electrode down, and that's what a picture is on the left. We can see that as the cells fire to the target. This is an example of Parkinson's disease, but similarly in tremor, we do something like this, where we identify that we have thalamic cells that are oscillating. Once we see that, we place the electrode and see an effect. The wires are what we see on the right as we're placing this electrode down to target. Now, this is a picture of the lead. So this is an important slide here. So we can see that there are, on this deep brain stimulation lead, this is the part that actually goes in the brain. There are 4 contacts. They're either small, spaced by 0.5 millimeters between each of the silver contacts, or 1.5 millimeters between each of the contacts. The 2 inner contacts are segmented, meaning that instead of them being round completely as a circle, they are segmented into 3s. And so that is useful, as that we can direct current away from structures and towards other ones. So as you'd imagine, as we're placing this electrode into the brain, we want to see very good effect, but we also want to see lack of side effect, because very close to the structure modulating the ventral intermediate nucleus of the thalamus or the fiber tract pathway, there are other structures which can cause side effects. So if we can direct current away from them, we have better ability to have a good effect without side effect. That is what these directional segmented contacts can do. And not only that, we can then have the ability to sense. There's some interesting information that's been relatively new within the past few years, that there's certain frequencies in the brain that we believe are pathologically causing the tremor associated with this fiber pathway that's running aberrantly. We have the ability, through this same electrode that we place, to sense this rhythm. And if we sense this rhythm, we can also more precisely target and use which contact we want to choose to stimulate to improve your tremor. That is something that's under research, but it's been used more commonly now. We have that ability. Again, it's important because as over time, your disease is changing, and we want all the best things we can to have to contain your tremor as your disease progresses. This is the 3D dimensional imaging. This is called the O-arm. Basically, in the operating room, before we leave the operating room, we want to make sure that we have indeed placed our electrodes at the target structure. So a patient will be basically laying in between this as they're kind of asleep or sedated, and we will make sure that we have electrodes at the right location before we leave the operating room. You'd want to have that before leaving, and then if we find out that they're not in the right place, we'd want to change it. So we don't have to do that by confirming that we're in the right spot. So there's many different ways that we confirm we're in the right location. One of the most important ways we confirm is that we will make sure that the patient is awake. So you will participate in part of the surgery. The surgery itself occurs in 2 different stages. The first stage is when we actually implant the electrodes into the brain. The patient will then stay overnight. They will then go home at the next morning. The second procedure occurs a couple of weeks later. We'll then have the wires we've left in their scalp to a battery put in the chest. So let me go over this, the actual surgery itself. So basically, a patient will come into the room, and they will have a frame placed. So this is basically, I'm going to skip to this slide here. So we're going to place a frame around the skull, okay? That frame is necessary for looking at 3-dimensional spaces where precisely we can place this electrode, beginning coordinates. Once we place that frame, we will then sedate you. You will be awake during the frame placement, but then you'll be sedated for most of the procedure. We will then get you in the position within this large O-arm ring. I'm going to skip back into this. And you will be laying within this. The bed will be inside of this area. We will then drape out. We'll make incisions into your scalp. We'll drill holes through your skull and put those wires down into your brain to listen to your cells fire. Cells firing will be like this. That gives us real-time proof we're in the right spot. And then we will stimulate, just like in this electrode. And that stimulating, we will make sure we're getting good effect without side effects. So in fact, I will wake you up and I'll see your tremor. Not only do we want to see good effect, but we want to make sure there's no tingling or type of a voice change. And is that necessary? It's not absolutely necessary, but it's something that we like to do as another confirmation that we are getting into the right spot, not just now, but 5 years, 10 years from now, we can use this electrode as we increase the stimulation, we're not going to have a side effect. Once we do that, we then do our final imaging on both sides. We secure the electrodes, tunnel them underneath your skin to an area around here in the back of your scalp. We close up. You will then go to the recovery room. You will stay overnight. Most patients will then go home the next morning. 2 weeks later, we come back for the second surgery where we connect back from the area behind your scalp. We then tunnel underneath your skin to a battery we put in your chest. This surgery is very short. It's about 30 minutes long. It's done as an outpatient under general anesthesia, so you go home after that. This is a depiction of what the whole device looks like. This pulse generator can last up to 5 years, depending on programming parameters. Typically, we like to implant a non-rechargeable battery initially, just because we don't want you to have to worry about charging it and get used to the whole the device, okay? After you're implanted, you're not necessarily turned on. Back to the slide. We send you to a neurologist that we work with. It may be the neurologist that referred to you, if that neurologist is happy to program, or we have a neurologist that we work with as a team. That neurologist will then program, and you'll see the effect of that tremor relief right away. It won't be optimal, though, because it's going to take a little bit of time to make sure all the parameters are correct. So it may take a few weeks of trial and error to make sure we're at the optimal settings. You will have an effect right away. The medication also has to be slowly withdrawn as that stimulation occurs. So I say about 1 to 3 months after we turn the stimulation on, you will have an optimal effect. That is what we'd expect. This is what the device looks like. You also have the ability to program this. So you will have a patient programmer. The neurologist will take care of most of these things, but say you're after your steady state and you're gone home, you don't have to visit the neurologist for every 3, 6 months, maybe even a year. Well, at home, you have the ability to notice that your tremor has gotten a little worse. You have the ability to just increase the voltage by a set amount. The neurologist will give you tolerances, and then you can contain your tremor. So every patient will have a patient programmer, and that's something that is very useful so that in between visits you can talk and you can play with it yourself and see what's best for you. Let's talk about the risks of the procedure. So there are risks of surgery, of any surgery, risks of hemorrhage and infection. Risk of hemorrhage here is less than 1%, unlikely to be symptomatic. This is very small considering all types of neurosurgery. The risks of infection are equally small, less than 1%. It varies around the world depending on technique. Luckily, I've been doing this for 15 years. We have a very good system going here. This lead the wires are plastic and metal. They are man-made and they can break. The battery is also a piece of metal. It can fail. It's less than 4%. The good news is that typically it doesn't break, but if it does, we can fix it. It does require surgery to remove any component, but we can fix any specific component. The wires that go in your head, the connection between here and the battery is called the extension. We can change out that wire, as well as this battery we know is only going to last 3 to 5 years at max. We will then change it. To replace this battery is a very straightforward 10-minute procedure done under sedation. And you will have indicators that will flash, or your neurologist will let you know when it's time to get the battery replaced, so you'll never have it die unexpectedly. You'll be monitoring it, or someone will be monitoring it for you. Efficacy. Well, the reason why we do this is to improve tremor. Most patients have greater than 90% improvement of tremor, and that's very common, and in fact, in my series. The good news about deep brain stimulation is that if you have tremor on both sides of your body, we can implant electrodes on both sides. If you have it on just one side of your body, we can just implant it on one side. If you have head or jaw tremor, that can also be improved drastically with stimulation to both sides. So if we place electrodes on both sides of your head and we turn them on, not only will we have both your hand tremor and leg tremor too, but you also have head tremor control. That is very important. This is durable, like I said, because we can increase the stimulation over time to contain that tremor. So now we're going to switch gears and talk about high-intensity focused ultrasound. Very many similar indications in the same disease process, but many differences to the surgical procedure of deep brain stimulation that I just talked about. So, adoption of focused ultrasound has been increasing throughout the last country. This is something that became FDA approved in 2016. It was research beforehand, so it's relatively new. It's been around only for about 7 years. This is a slide showing the top 20 centers, the hospitals for neurology and neurosurgery, and by U.S. News and World Report. And Northwell Health is number 20 here. The blue signify the centers that actually have focused ultrasound machines. So most of them do. 70% of the top 20% of top 20 neurosurgery and neurology systems in the country have it. Something that you'd want to have. This is a center you want to have the ability to do not only surgery, but non-surgical ways to improve tremor. This, as we mentioned, this is something that's been also slowly increasing over time. It became FDA approved in 2016. It's gradually been increasing because of its ease of use. It's for patients who don't want to undergo surgery to improve their tremor. And it's for patients basically who are tired of having tremor. They have another option to help them outside of medications and surgery. So what exactly is focused ultrasound? So as I mentioned, we will basically be focusing ultrasound beams up to 1,024 sound waves. We'll place a helmet over your skull, and we'll focus those ultrasound beams through your skull without creating an incision or doing surgery to the same area that we're targeting in deep brain stimulation, the ventral intermediate nucleus of the thalamus. Only when those sound waves converge will we then increase the temperature significantly to cause ablation of that target. It's very small. It's very precise. We increase the temperature to a high enough degree to create thermal ablation. That's how we create this lesion. It's very precise. So we're not destroying any of the tissue as those sound waves converge. Only when they're right at that certain point do they create that lesion. It's very precise. There's no worries about going right through any other parts of the brain to create this. This procedure is done in an MRI suite. It is not done in the operating room. At North Shore Hospital, this is the new MRI suite is adjacent to One Cohen. It's very nice. This is where a patient will arrive on the day of the procedure. This procedure occurs as an outpatient, so the patient will be going home the same day. This is an overview of what this looks like. So a patient, after they get a frame placed and they basically have a membrane that's then placed over the scalp, the patient will then be walked over to the MRI scanner. That's just as we're seeing here. They'll have this helmet placed, and then they'll have some sequences performed, and then we will perform some sonication. So that's the fancy word of how we're creating this lesion through the skull to create this effect in the ventral intermediate nucleus of the thalamus. That's what this slide here is depicting. The fancy focusing of those sound waves here, but I'm going to show this again because it shows how this. Here we go. So this is the helmet. You'll be laying in there. You are awake continuously during this procedure, okay? You're only in the MRI part for about maybe up to a minute, maybe 30 seconds for each sonication. So we will get an MRI prior to we doing this procedure, actually a couple of days before, so we can limit the amount of time we actually have to spend in this MRI scanner. That is also very useful. So each sonication that we do is very short. So you'll be coming in and out of this scanner on that table as we perform the sonications to ensure that we're getting what we need to do. So this is a description about how we're actually creating this lesion. So here, as I mentioned, we place this frame. And then after we place this frame, so prior to placing the frame, let's back up, we actually have to shave your head, okay? That's a very important thing. We shave your head because we want to make sure that there is no hair that is going to interfere with how we're performing or how we can converge these sound waves. If there's any bit of hair on your head, that will basically refract the sound waves and we can't do as successful a lesion as we'd like. It's not just our center that does it, it's kind of everywhere in the world. So this is a worldwide phenomenon where we have to shave your head. So while we're doing this, we then place we place your frame. We then place a membrane over your scalp that will hold water to cool down your scalp as we're performing these procedures. We then walk you over to the MRI scanner, just like you are seeing here, and we'll connect your frame to the bed. And then you can see we're testing you. So you are awake during this procedure. We're going to have you draw spirals, and we're going to have you hold your hand out and hold things, and we're going to see your tremor continuously. That is important for you to be awake so that you can let us know that how you're doing, how your tremor is improving, because we're going to see real time in front of you how your tremor is improving. But we're also going to make sure that there's no side effects, because if there are, we have the ability to change the target by a little bit to make sure that we're not going to have a permanent side effect. So while we're creating these sonications, we don't have to create a lesion right away. What we can do is stun the cells by not increasing the temperature high enough. We can just basically, which is called the physiologic verification section. After we've gotten some scans to make sure that we're targeting the right location, we will then do a lower power sonication, just like we may test in deep brain stimulation. So we are testing to make sure that we're getting a good effect before we actually create the permanent lesion. You will let us know if you feel any tingling. Typically, it would be tingling around the lips or in your fingertips, as well as we're going to see good effect. Once we verify all that and you let us know everything is good, we will then perform the lesion, which increases the power, therefore increasing the temperature that we can see using MRI thoracoscopy. So once we perform this verification, perform the lesion, that is the treatment. And the treatment is done. Patient can then go home and recover. This is how we're lesioning it. The interesting part about this, as I mentioned previously, as opposed to Gamma Knife, is that we see the effect in the MRI right in front of us. We also have an immediate effect as opposed to a delayed effect. Very important. Let's talk about the clinical, the efficacy. So most patients have about a 90% improvement, just like deep brain stimulation, after we perform the focused ultrasound. Unfortunately, though, tremor is a progressive disease. We are creating a roadblock by this lesion, by having these fibers being stopped. But over time, those fibers can leak around this roadblock, and then they start progressing. So although we're creating an improvement right at one time, it's not going to be as great as time goes on. So as I said, this has not been around forever. It started in 2016. There's only been a few studies that showed at the 3-year time point what has actually happened at this. And so what we see at 3 years after this procedure occurs, we still have a very good improvement, about 75% of tremor control as opposed to 90%. So it's pretty decent, which is good. There are side effects that some patients do experience, and one of the most common side effects after this procedure occurs is that there's a little bit of an imbalance. The imbalance is something that does not necessarily occur immediately after the procedure, but it's due to the fact that we're creating a lesion, that there's some swelling around this, and that swelling around this, called edema, takes about a few days to a week to come and then go. Sometimes it takes a few weeks. While that edema is there, that swelling, which we will give you steroids for to mitigate, that can lead to some ataxia or an imbalance. It also could lead to a little bit of tingling that may not be present at the time of the procedure. That will also improve over time. In fact, most of these side effects that have been seen in this report resolve within the first month after the procedure. At 3 years in this specific report, most of those side effects are typically gone. So importantly, that's why we're doing this pre-lesional sonications to test to make sure that we're not getting a bad effect. But if we do have one that evolves after you leave the hospital, it's likely due to swelling, which will improve over the next few weeks. So, patient selection. Just like patients for deep brain stimulation, patients have to have a confirmed diagnosis of essential tremor. This is the high-intensity focused ultrasound is also FDA approved for tremor-dominant Parkinson's disease. That is a different disease than essential tremor. That's not what we're discussing here. For essential tremor, you have to be 22 years or older for focused ultrasound, 30 years or more for tremor-dominant Parkinson's disease. As different than deep brain stimulation, where there is no age cutoff at all. There is no upper age limit. In deep brain stimulation, you could be at any age as long as it's ethically sound, and everyone agrees. You also, as we mentioned, we have to have the patient awake completely during this procedure. So we have to have you be able to tolerate the procedure without any form of sedation. If your patient's claustrophobic, that could be somewhat of a worrisome thing. typically, as I mentioned, we're not really in the MRI scanner the whole time. We're kind of in and out on the bed, sliding in and out of the actual tube. So we're not really sitting in there and being anxious. It's only about 30 seconds for each sonication, and that's a very short time to have. You have the ability to communicate what you're feeling during the procedure in case we have to change the position. We want to make sure you have the best effect. Obviously, you need to fit in the MRI scanner, and you also need to be able to able to have an MRI. If you have a pacemaker that's not MRI compatible, or cochlear implant, or a stent that's not MRI compatible, that is not going to make you a candidate for focused ultrasound. What do you expect after the procedure? Well, immediate and durable tremor improvement. Right away, you will have tremor improvement. In fact, as soon as we take you out of the scanner, take off your frame, you will have a glass of water and a sandwich, and you will be amazed about how well your arm cooperates and your hands cooperate. Your quality of life will be significantly apparent. You'll go home the same day. There's obviously no risk of infection. We're not implanting anything. Minimal amount of complications. It's very, very useful. Contraindications, as you just mentioned, is that you have to be able to have MRI compatibility. So nothing that's been implanted as a pacemaker that's not MRI compatible. These are the important things we need to know. So if you have something that's implanted, basically you should have a card. That card you would then we could then send to the MRI technician or the MRI people, and they would let us know whether you're compatible or not to have an MRI, or you would know that. One of the other important things that we do as a screening process is that we have to get a CAT scan prior to we do this. So the CAT scan is of your head, and that looks at the skull as well as the brain. What we want to look in the skull is basically the skull density ratio, or the difference between the inner and outer table. That is important because if it is too low, then we can't focus those ultrasound beams well enough to create this lesion. So we want to make sure that the skull density is not too low. So if it is, then we can't necessarily perform this lesion, and it's a waste of your time. Most patients, more than 90% of patients, are candidates. But it's a very quick screening process that is very important to do because we want to make sure that we're going to get the effect that we want. As times change, we might be able to accommodate even lower skull densities ratios, but right now it's about 0.4, 0.45 is our limit. Patients who are pregnant are contraindicated. We typically choose patients with most comorbidities are candidates. Patients who are not surgical candidates would be very good candidates for this as long as we can take them off their blood thinners and they can tolerate being in an MRI. So I alluded to this before, but we're going to go this over a little bit more succinctly. So this is the day of the procedure. So you can see on the first part, the patient is shaved. That is very important. We shave your head when you come into the MRI suite. And that is because we don't want any hair that's around to refract the beams to cause a problem. We will then place the frame on. The frame is we give local anesthetic, numbing medicine, into your scalp. And then we put these pins into your scalp, into the skull, to hold this frame. This frame, just like in deep brain stimulation, is a stereotactic frame. When we get a scan, an MRI scan or a CT, with this frame on, it produces coordinates to the anatomic structures that we want to use. So this gives us coordinates that we then can precisely target the locations, such as the VIM thalamus, that we need. Once we do that, we will then place this thin membrane over your scalp. This membrane is a plastic piece of plastic that contains water. During this procedure, we'll fill it up, and that will cool the scalp down as we perform the sonications. We'll then walk you over to the MRI scanner. We then will perform planning, as I mentioned. We want to look at making sure we're getting this target in 3 dimensions precisely. So we'll get some sequences. Although we have, prior to the actual procedure, we would have gotten a large MRI for all this planning things. We have to get, just every time we do a procedure, an MRI, we have to get an MRI at that time. It's a 5-minute scan. We'll do the bulk of the scanning at a different time. This 5-minute scan is done. We finish our planning, and then we do these pre-lesion sonications. So that's where we will have you move your hand and do some writing samples while you're laying down in the scanner, conversing with us while we do light doses of energy we apply. Those light doses of energy are necessary to see effect, as well as making sure we're avoiding side effect. And then if we do see a problem or we're not getting as good efficacy, we can make those changes before we create a permanent lesion. Once we're satisfied, we create the actual lesion. Sometimes we create more than one. It depends on the degree of tremor that you may have. the goal is that we want to increase the energy high enough to really improve that tremor. That's why you're testing us. That's why we can see if we're done or not. If our tremor is not quite extinguished as much as we'd like, and the patient can tolerate it, then we would continue with another sonication treatment. So this is a picture. I'm not sure it's going to come up here. A video. I'm going to show before and after treatment. I'm going to try to hit this button. You see a patient on the left before treatment, a patient on the right after treatment. You can see that there's probably a lot of patients that have this type of situation. You're not alone, but the effect is right away. Drinking is one of the biggest problems, getting that cup to the mouth. Look at how nice and smooth it is afterwards. So it is an effect that is seen right away. So this is a slide showing actually what we're doing in the brain. So the one on the left shows the brain location before we do the brain before we do the actual sonication. After we have a successful treatment, the one on the right shows the area that we targeted in the blue arrow. This white area is the ablation, the area of the brain that we have destroyed to improve this patient's tremor. This is a little bit of edema too. It's not exactly the lesion, but what it is shows that we've precisely targeted the area that's causing the problem, having an amazing effect. This is seen about 15 minutes after we finished our last sonication. Insurance covers this procedure for essential tremor. Medicare covers it in all states. Every other type of private insurance is different. And so in New York, it varies, but most patients have coverage. With this, it's really something that you can certainly inquire and let us know if you come visit about what insurance is. But the most important thing for insurance to cover this procedure is that you need to have a bona fide diagnosis of essential tremor that is medication refractory, means you've had tried medication, it's no longer helpful to you, or tremor dominant Parkinson's disease that is bona fidely made by a neurologist. So here I'm going to play this video. Okay, so not sure you can probably hear what she's saying, but this is a patient they're getting ready to have this procedure done. You can see her tremor. This is here, and she can't do as many things as she would like to do. And this is before. You can see that tremor is pretty apparent in her hand. This is an example of putting them into the MRI scanner, creating the targeting of the lesion. We see that we're having an effect right there on the table, which is quite amazing. Afterwards, she's back to do all the things that she would like to do, knitting, drinking, using her hand in the way that would be most beneficial to her. So this is a huge improvement of the quality of life for her right after surgery, and everyone is very happy. So, basically, we started this program back in April. We're the first center on Long Island to perform this procedure. As of May, or at the time we did this, we had 10 patients treated. Probably this is about an old slide about a couple of months ago. We've had more than that. We've had 15 patients treated to this point. The slide on the bottom there showing the spirals and the lines. This is what a patient would do before treatment. So we would see how they can't necessarily draw very well, keep the pen within the lines, and they can't sign their name very well. This is immediately after the procedure. You see how well they can very smoothly draw that spiral and that line, as well as sign their name. So a huge improvement that is seen. So that's pretty much what we're going to talk about today. If you have any questions, you certainly can come call us, make an appointment to see me, or just talk to us online, send us emails. We're happy to discuss anything about this process, for not only for focused ultrasound, but for deep brain stimulation. One of the things that I'm not sure if it was very clear to you, and I want to mention, is that focused ultrasound is something that is useful it's only FDA approved for a unilateral treatment, meaning that if you have tremor on both sides of your body, we can only treat one side of your body at a time. 9 months after the first side is treated, we can do the second side. So we can't treat both sides at the same time. Similarly, because we can't treat both sides at the same time, we will not be able to improve head or jaw tremor with focused ultrasound. Deep brain stimulation, on the other hand, if you do have tremor on both hands as well as head, we can place electrodes at the same time to the target area. So that's something I'd be happy to go over with anyone who wants to come talk to us about the different options that are available. Once you just realize that you don't have to live with your tremor. If your tremor is significantly affecting your quality of life, there's medication. Medication's the first route, but after medications, and you're still dissatisfied, there are options, and that's what we're here for. So I thank you so much for your time. I hope this was informative, and please come visit, and we'd be happy to discuss more. Thank you so much. Have a great day.